So the clinical question I want to bring forward today in relation to anemia and sickle cell disease is, can a point-of-care device be implemented to detect drops in hemoglobin level before the onset or during onset of vaso-occlusive crises and pain crises? To which I don't have a full answer, but this is the question I'm giving you for food for thought. So as a reminder, traditional testing methods for hemoglobin levels, specifically in developed countries, often involved a hematology analyzer to give a CBC result. This involves venous phlebotomy, trained technicians, often multiple steps and sites, and they are quite expensive. Even point-of-care options that are currently out there often require batteries, electricity, and most of which are not suitable for point-of-care settings. So with all of this motivation, our group at Georgia Tech, Atlanta, Children's Healthcare of Atlanta, and our small startup, Sanguina, have come up with the AnemoCheck anemia test. This is a test that correlates color to total hemoglobin levels. It's rapid, simple, disposable, equipment-free, apart from what you see in front of you, and results can be obtained in 2 minutes real time. The test is very simple, so if you follow with me on the right-hand side of your screen, after performing a finger stick, 5 microliters of blood completely fill a capillary tube. This gives us an exact amount of blood that we need, so we have precise volume control. It is then mixed with our AnemoCheck chemical solution, and after 2 minutes, the resulting color correlates to a hemoglobin level. As you can see, the colors range from blue to red, blue indicating low levels of hemoglobin, red indicating higher levels of hemoglobin, and these can all be interpreted with the naked eye. So before I go into the development and current clinical studies, I have to say that Sanguina was spun out of Georgia Tech and Emory University. We maintain close connection with them, along with Children's Healthcare of Atlanta. We also have collaborations with Cincinnati Children's and the Centers for Disease Control and Prevention in the United States. The AnemoCheck technology was initially developed in 2012. This graph I'm showing on the left is actually quite dated, but it highlights that with the chromogenic reagents we're using, we can visualize lower and higher levels of hemoglobin with different, very different color curves. So this was done with spectroscopy on a well plate reader, and we see very different color peaks consistently correlating with lower and higher hemoglobin levels. This was done at Georgia Tech when I was actually an undergraduate student, and it really proved our proof of concept for the color scale. To build upon that, we thought it was necessary to test this in actual patient populations, so we started our first clinical study at Children's Healthcare of Atlanta and Winship Cancer Institute. We tested our device on 238 adults and children, and we collected data on our test versus the gold standard CBC machine. If you can imagine, this is the $150,000 US refrigerator-sized machine. And what we found was a great correlation. The graph on the bottom right shows our 95% confidence intervals in dashed lines, and very few of our data points actually fall with outside of these lines. This highlights that there's a great correlation between the two methods with visual naked eye interpretation. I'm also highlighting our initial sensitivity and specificity values in the bottom left. As you can see, they ranged from around 84% to 95%, and these results were published in the Journal of Clinical Investigation in 2014. We also wanted to assess our device in the hands of a low resource setting, so we partnered with Cincinnati Children's, two of my collaborators who I don't think are here, Patrick McGann and Russell Ware, with one of the clinics they work with in Angola. This is a sickle cell and maternity clinic. We tested our device on 86 Angolan children with sickle cell disease and compared our visual results with their hematology analyzer, which is called a Seismix. And the graph on the right is showing you that there was also a very good correlation, the perfect anticipated line versus our line in the dashes. And we wanted to highlight that 90% of the samples were within 1 gram per deciliter of Seismix results. This is important to discuss because in any hematology analyzer there is a standard deviation associated with it, and really if you can hone in on a hemoglobin level within 1 gram per deciliter, that is acceptable. These results were published in the American Journal of Hematology in 2015. Most recently, I wanted to highlight our best data. We've improved our chemical formulation, and on the bottom left, what you see is our visually interpreted results via a different, compared to another point-of-care test called the HemoQ 201, which has been implemented in some low-resource settings. You can see, again, a very tight-fitting trend line. This was done on 206 samples, all with varying diagnoses. We had some cancer patients, some sickle cell, some aplastic anemia and whatnot, and you see a tight correlation with an R-squared value of 0.97. On the right, I wanted to give you a more broad view on our entire range of sensitivity and specificity using a receiver operating curve. Here you can really view how sensitivity and specificity vary when compared to one another based on this data, and we do show a tight fit. I also want to highlight at the bottom, very similar to what I talked about before, that our sensitivity and specificity values are here and have improved, now ranging between 93 and 100%. It's also worthwhile to mention that through this development, we've also seen that we can actually shift the color scale. So, for example, you may think that detecting 10.0 grams per deciliter may not be useful for a sickle cell disease population, and that is indeed true. So what we can do with our chemical formulation is shift it right to left along the hemoglobin scale. And on the top image, what you see is the scale used in our Angolan study, where detecting between a 6.0 and a 4.0 hemoglobin level was much more important, so we were able to shift the entire blue to red scale over. This allows for customizable and target hemoglobin ranges. For example, in the United States, on the bottom, 10.0 and 8.0 are more clinically relevant thresholds. So we have the ability to shift, which I think can be utilized in the future. So I want to go back to my clinical question that I talked about in the beginning. Our team at Sanguina has come up with, I think, 2 potential sickle cell disease use models that are worth exploring. Our first generation device, which I've presented to you today, is projected to retail between $1 and $3 US per test. That said, I think this model could work for middle income to high income countries for sickle cell disease patients and parents for monitoring hemoglobin levels at home. So again, the question that we're trying to answer is, can we detect drops in hemoglobin level prior to or during onset of vaso-occlusive crisis? And we are happy to say we are midway through a pilot study with Emory and Children's Healthcare of Atlanta with Dr. Clark Brown and Wilbur Lamb, where we're having patients and children take these tests home over the course of 6 months. They are testing themselves every week, and we are comparing with CBC results whenever they get them. But another thing we're gaining from this study is information on usability. How easy is this for a patient or a parent to implement at home? Are you comfortable performing a finger stick on your child? To which I can say that, at least on the surface, preliminarily, we have seen that sickle cell disease patients ranging from 8 to 12 years old are comfortable performing this test on themselves, and their parents have been relatively just supervising. So I also wanted to mention that in this model, we have noticed that some of the children become very passionate about our device and passionate about where their hemoglobin levels are. And so it speaks to a little bit of what the previous speakers have touched upon on empowerment. We are noting that even in the youngest of our children using it. And my question to the audience is, does this fit a use model in India? I know that in the lowest resource settings, this may not be the case, but are there middle income areas and high income areas where monitoring hemoglobin levels at home could benefit? And then secondly, we've come up with a use model for the global health settings. We recognize stability limitations with our first iteration as well as pricing limitation, and we have acknowledged that a robust temperature and humidity tolerant device will be necessary. In this model, it's proposed that there would be a test for anemia, very quick and simple, potentially at home, prior to an in-depth definitive sickle cell disease testing or viral or bacterial testing. So this test would be used to direct the next steps in triage. In this example, a positive anemia result could lead to more definitive testing. And we would indeed need to partner with local sickle cell diagnostic initiatives and companies. So with that said, I'm happy to show you guys, for the first time, some preliminary data on our second generation AnemoCheck test. What I want to highlight is that we're moving to a dry form technology which will enable storage at high humidity and high temperature settings, which is always a concern when trying to market and implement in low resource settings. What you see on the left is two different scenarios. We've stored these tests room temperature, so that's about 22, 24 Celsius, over 3 weeks, and then performed a test on a low and a high hemoglobin level. And then on the right, what we have is the same tests that were stored at 60 degrees Celsius in 100% humidity over the same time period, producing very similar results. That said, with dry form technology, we have the ability or the option to explore different packaging materials, different packaging embodiments, which can really drive down the cost down to where several of the speakers have mentioned today needs to be below $1 US per test. And the whole goal of this generation would be to ensure accuracy and stability in low resource settings that need it most. So moving forward, I want to touch on our plans. We plan to obtain clearance of our first generation in the United States and EU. We plan to continue our development of the second generation throughout 2017. And we plan to conduct clinical studies in field in low resource settings in 2018 and hopefully gain some insight into our clinical questions. We will also endeavor to network with global partnerships and companies for implementation of a second generation device. I have to thank our funding sources, the National Science Foundation, Children's Healthcare of Atlanta, and Georgia Research Alliance, as well as our joint university, Georgia Tech and Emory University. And this is my lab back at Georgia Tech, back in Atlanta. They all say hello to you guys. So I thank you for listening to me today. I know it was different than our traditional sickle cell conversation, but I'm happy to entertain any of your questions. And if you need to contact me afterward, I have my email address on screen. I will be running out, but feel free to send me an email. Thank you.